Hi, everybody. This is Dr. Narda Robinson, founder and CEO of Curacore Vet and Curacore Med. Today's topic will be elbow pain and how to do better. Elbow pain is a difficult condition to treat, even with humans, dogs, cats, whatever, because it's a complex joint. But if we take a fresh approach and think about more elements than we've been taught to consider, so fascia, the soft tissues, because not everything is just a bone or a joint problem, and we have more therapies that we can bring to bear on the patient's condition, so medical acupuncture, photomedicine, therapeutic exercise, different things, then we can get better results. So how big a problem is elbow pain in dogs? Here from Canine Medicine and Genetics in 2020, the authors wrote, elbow joint disease is a relatively common diagnosis in dogs and has a high welfare impact as evidenced by the high proportion of cases recorded with pain, lameness, and analgesic therapy. So they continue, the most common specific variants of elbow joint disease, now remember, this is as they were diagnosed by veterinarians trained within the conventional framework that has been veterinary medicine for decades, centuries. But anyway, the most common specific kind of diagnoses were osteoarthritis, that was 76%, elbow dysplasia, 31%. So some of those are going to be both, because that's more than 100%. And traumatic, 7%. The most common signs described by the owners or parents were lameness, difficulty exercising, and pain. And then the most common findings on the exam were pain, lameness, and reduced range of motion. But again, when we look at that, we can think, well, how many veterinarians there were performing a myofascial palpation exam? How many were looking at posture? So the how to see a dog that we've covered elsewhere, looking at posture form and function from nose to tail and top line to toes, and just getting a general sense of the comfort of that animal, including hair coat, temperature, and the longitudinal anatomy, so long lines of force and compensatory patterns, thinking of the long fascial lines, but all the myofascia that connects from one body region to another. So we have that in mind. This is what we're starting with. And then the most common medications used were NSAIDs, so non-steroidal, anti-inflammatory drugs. That was 88%. And we know, there were problems with that. Tramadol, there are problems with that. And disease-modifying agents. Of 109 deaths involving euthanasia, with information available from the 616 incident cases they were studying, elbow joint disease contributed to the decision to euthanize in 45. So 45 out of 109 deaths where elbow joint disease was part of this whole gamish. That was 41% of the dogs had euthanasia related to the elbow pain. So, like I just said, what about those diagnoses? Did they include movement, posture, myofascial? And if we only look at bones and joints, is it any wonder that so many practitioners resort to drugs and surgery? Because generally speaking, it's not thought that there's going to be that much change in the bone itself. There will be some, but not that much change even with integrative rehabilitation and physical medicine. But we can improve bone health, but then you have the joints as well. Again, we can make some improvements, but what is missing? It's all the soft tissue. And what's in the soft tissue? We will be covering that. So where does elbow pain originate? You just take a look at this illustration, and the muscles are missing. The skin is missing on the side that we're getting this window into the body. What can we see? We can see nerves in yellow. We can see arteries and veins in red and blue. We have some lymphatic structures in the green, and then internal organs and bones and all that. So there's so many different structures that we can think about. And then here, just on the bottom of the screen, we see the elbows. But so what is there around the elbow? Well, there are muscles that's going to make them move. And where do those muscles attach? Well, sometimes they're going pretty far. They're not just at that joint location. So if we were going to palpate them, we have to think about not only where they are in terms of their crossing, but where did they originate? Where are they inserting? How are they moving? How are they feeling? What's the consistency? Are they just persistently contracting and shortened? If they are they squishing a nerve or some vessels in the meantime? What about the fascial tunnels that the nerves come through? Is the fascia compressing nerves? Is the fascia too tight? Is it too loose? Is there ligamentous laxity? And what about that joint deterioration for things like osteoarthritis? It's not just degeneration, but there's an active process there of inflammation and improper signaling, or let's say just abnormal signaling or disease type signaling. And if we can influence all those endogenous physiologic processes with integrative rehabilitation, physical medicine, then isn't that great? We can start earlier once we start to see the small problems develop, but intervene even when it's later. So why have so many structures been ignored for this long? Is it because the surgeons, now think about it, when did you learn about elbow disease in vet school? Was that during orthopedic surgery or was it during internal medicine? Was it during neurology? Or did you even have a class in acupuncture? No, you didn't. So it was probably during your orthopedic surgery class. And what do surgeons do? Typically, is they're working with bones and joints. I remember in vet school when I was there back when, and I was also, at the time, I had already started the medical acupuncture service at Colorado State University. There was a patient there that they were having difficulty kind of ascertaining, well, why is this dog so lame? And I did my myofascial palpation on the dog and said, well, there's a big, tight, and very tender trigger point in the triceps. And the orthopedic resident kind of looked at me like, what's a trigger point? And I was like, where do I start? So commonly described causes of elbow pain in dogs: elbow dysplasia, elbow arthritis, which we assume is osteoarthritis, and osteochondritis dissecans, sometimes you'll see it dissecans, or OCD. And so again, when we're thinking, okay, what is the problem with this dog? Even when I've tried to look for more literature on the topic, more discussions online, YouTube videos, what can we look at besides dysplasia, osteoarthritis, and OCD? There's just not much there. And so what's missing? We've already talked about it, nerves that get squished as they go through their tunnels or under some tight bands of muscle or tendon or fascia. And then the muscles themselves that can get dysfunctional with overuse or strain or repetitive motion, or just having to run by your neck being pulled by somebody that's on a bicycle that's going faster than is comfortable for you, and you're having to deal with your neck not only being pulled, but not wanting to get into the bike tire and on potentially hot and hard pavement. And it's just a mess. So do not take your dogs for runs on the bike. And then vessels can get compressed also. And then when those are compressed, you're getting inadequate circulation, inadequate oxygenation, and nerves get really unhappy when they don't have enough oxygen. So just a big field that you now kind of sometimes see in human medicine, but you kind of don't ever see pretty much in veterinary medicine, at least not in the courses that I've seen, but we do talk about it in MAV and MOVE, entrapment neuropathies of the arm. This is just the arm, but think of the different nerves that supply the elbow and distal. Well, we have the radial nerve, we have the ulnar nerve, we have the median nerve, and a little bit of musculocutaneous nerve. That's one that people often miss. And so, as discussed in this American Family Physician article on peripheral nerve entrapment and injury in the upper extremity, they say peripheral nerve injury of the upper extremity commonly occurs in patients who participate in recreational and occupational activities. They're not even talking about a quadruped who spends most of their lives, all of their lives if they're walking, putting most of their weight on those front limbs. Imagine if we did that. And then they say nerve injury should be considered when a patient experiences pain, weakness, or paresthesias, which we don't have babies to tell us, in the absence of a known bone, soft tissue, or vascular injury. The onset of symptoms may be acute or insidious, and nerve injury may mimic other common musculoskeletal disorders. Yeah. And so why cut? Why put on potentially injurious anti-inflammatories for the rest of their lives when there are other things to do, when there are other causes that you didn't even think about? So, for example, aching lateral elbow pain may be a symptom of lateral epicondylitis, which is often kind of that wastebasket diagnosis. Oh, my elbow hurts, doc. What do you think it is? And they'll say, oh, tennis elbow here, blah, blah, blah. But it could also be radial tunnel syndrome, where that radial nerve is trying to go through its little tunnel on its way towards the distal thoracic limb. It could also be a patient that has a shoulder pain and weakness with overhead elevation. Yeah, their rotator cuff might have an injury, but it might be a suprascapular nerve entrapment or problem. And then pain in the forearm that worsens with repetitive pronation activities. Yeah, could be from carpal tunnel syndrome or pronator syndrome, which is actually in the elbow and not the wrist. So palpation and understanding of anatomy, and especially neuroanatomy and where these things are going, but also myofascial anatomy. So you see, oh yeah, you know what? I know where that nerve is likely being hammered, and that's not down here. It's, oh yeah, there it is. So it's about learning the fact that these structures and problems exist, and then implementing them into your practice, and not just saying, oh, dog has elbow pain, dog lame, must be dysplasia, arthritis, or OCD. Just those three. Otherwise, I don't know. Send them to that integrative medicine practitioner down the street. Maybe they'll know something. Anyway, specific history features are important, such as the type of activity that aggravates symptoms and the temporal relation of symptoms to activity. Like, is there pain in the shoulder and neck every time the patient is hammering a nail, or is it just when hammering nails overhead? So that helps in the human, helps you isolate that mechanism of injury and where that mechanism is impacting the structure. The ulnar nerve and the radial nerve and the median nerve, they're all kind of going to be unhappy if she continues to do that. And so hopefully that was just for a momentary photo shoot. But anyway, plain radiography and magnetic resonance imaging are usually not necessary for initial evaluation of a suspected nerve injury. So what we've been taught again in orthopedic surgery, oh, let's snap some rads. Put them up. Yep. Elbow looks normal. Elbow looks fine. Put them on NSAIDs. How about feel the dog, identify the entire circumference of the soft tissues, and find out where there are problems and monitor how their expressions are, how their respiration is when you're doing that, but also monitor, most importantly, monitor what your hands are feeling in a gentle but astute and focused and informed palpation manner. So, recovery of nerve function is more likely with a mild injury and a shorter duration of compression. So, let's do that early. Let's do that well before anybody even thinks of bringing a scalpel. Recovery is faster if the repetitive activities that exacerbate the injury can be decreased or ceased. So, stop dragging your dog on a leash behind your bike, client. Initial treatment for many nerve injuries is non-surgical. Well, you have to identify it before you non-surgerize it. So here, do it yourself. Let's talk about muscles of the forearm. Here's some practice for you. So here is an artist's rendition of the posterior compartment, which we're talking about the dorsal compartment of the right arm. I'll get that out. Superficial and deep layers. Now here are the concepts. Look at the proximal and distal extent of this forearm. Look at all these attachments around the elbow. But think of that elbow as a fulcrum, that pronation, that supination. All that has to happen. Now that's more in the human than in the dog. But there's just a lot of force being generated at these tendinous attachments. And as you can see here, that on the superficial aspect, we can feel, palpate. So this is a DIY. Palpate from one end. So palpate from the wrist, and you can feel a tendon here. And then follow that, and we're going cross-fiber palpation. We're going to follow that all the way, and you're probably also already feeling some tenderness. As you do that, press it and kind of squish that tendon back and forth, and then it becomes, oh, right there. That's where that tendon becomes a muscle, and that's the myotendinous junction. Do you remember what type of proprioceptor inhabits that myotendinous junction? And then we get into the muscle belly, So here, and about that midpoint of the muscle belly, there's that central trigger point, ow. And a lot of times when you do it to yourself, or I'll do it to somebody else, it'll trigger a local twitch response, and you can see the hands move or something else. But all that is tender. We can follow that all the way up. So note to self, when you're palpating, don't just go for the middle of the muscle belly. You want to feel the whole muscle attachment. But if you do this and even start to go circumferentially around like this is much more tender. This is more of a deep ache. But you can feel that ropiness. Ow, that really hurts. And that's an ache in my elbow. And so when these animals have pain, it may not be in the elbow, may not be something you can put with the radiograph and look at it because it's not going to show up on radiograph. It'll show up on palpation. And you're going to examine that. And it's not just one muscle or one tendon. There's going to be usually a whole functional group of overuse syndrome affected muscles and tendons. And then don't even just forget the extensors. Think about the flexors too. So extensors are going to attach to the lateral epicondyle up here, and then flexors attach at the medial epicondyle down here. Different innervations, different functions, but all important. And then when you see these drawings, you can see that if we're going to go cross fiber here, if we go deeper, there's different angles to muscles because our forearms and our hands are so complex. And then we can get into the whole group of flexors as well. So it's just a lot to consider and examine. And so to keep in mind, but that's what's going to improve your diagnosis. And yes, you might feel nerves there, but know that if there is a nerve entrapment problem, there is probably some tenderness to palpation around there. So do it yourself relief of nerve entrapment. Here's a fun exercise. And let's say that just to give you an example of some movement that can help, and this is human, but it's easy to demonstrate to you and have you pick up. And so if somebody is, let's say, sitting in an armchair for a lot of time and reading a book and compressing their ulnar nerve, and they're like, why do my fourth and fifth digits feel asleep? Am I going crazy? Is my neck a problem? Am I going to die? No, it's because you've been resting your elbows on your ulnar nerve. So here is a type of physical therapy-ish exercise to undo that entrapment and tension in your ulnar groove and the poor little ulnar nerve that's getting squished. And it's kind of complex. And I have a bat here. This is reminiscent of Batman because this makes me think of Batman, this exercise. So you're going to put your thumb and forefinger together like this, but you're not going to go like this. You're going to go upside down. So my fingertips are on my mandible. This is the Batman exercise for ulnar nerve entrapment. What is it doing besides making me look funny? Well, what's it doing here? It's opening up all these muscles and fascia that are compressing the nerve. And it's really great. It's really great to do because I was having a problem with that. I was speaking in Montana many years ago. And just to get groceries for being at the hotel, because I'm a vegan, it was Montana, didn't really have vegan stuff there. So I had to go to Walmart, as such as it is, across the street where they had a supermarket. But it was a busy street. So I had to go all the way down the street, go to the light, cross over, go all the way back, and then go to Walmart down the hill. And I got a lot of Diet Coke also with my groceries. And so I had like 20-pound bags in both hands. I'm bringing up the hill, going all the way back to the hotel. And for 3 years after that, I was having trouble with my ulnar nerve being entrapped. And so these things can happen from just one activity and then plague you for a long, long time. And I had identified what the problem was, and I had a lot of massage therapy, and it just took a long time to undo that. So that's just something you can do on your own that is an example of different movements we can do to loosen the myofascial restriction there. What are some other things we can do for the elbow pain? We can do acupuncture, so medical acupuncture at the trigger points. We can release that myofascial restriction. We can tune up the nerves so we can we can free the nerves, we can improve the oxygenation locally because acupuncture is going to help blood flow normalize in and outside of the area. It also has anti-inflammatory effects. It has a whole range of effects, but just for the elbow problem, once we've identified the myofascial strain patterns, then we can use acupuncture if we use the main approach, so my medical acupuncture and integrative neuromodulation approach, we can choose central points for the spinal nerves and the spinal segments that they come from to improve the health of that nerve as it's coming down into a peripheral nerve. So we would use caudal cervical points, maybe cervical thoracic points, and probably the extra points on the side, those cervical special points where the ventral rami are coming out before they form that brachial plexus. And then we'd identify that whole strain pattern because it's not going to be just in the elbow itself. It's going to be likely a whole strain pattern that goes down to the digits. And don't just think of the dorsal surface, think of the more internal surface, so not just the extensors, but also the flexors, and address accordingly. There will also likely be some neck pain. What else can we do? We can do photomedicine, and that's going to overlap with a lot of the effects of acupuncture, so improving circulation, relaxing the fascia, anti-inflammatory effects, reducing swelling in the area, helping restore just the tissue regrowth. So both medical acupuncture and photomedicine will help to activate those progenitor cells in the tissue, so activate just the resident stem cells for tissue repair. But we probably don't need to go that far with just generic elbow pain. Even if there's a bunch of osteoarthritis and osteophytes, if we can normalize that milieu and the signaling in the area and reduce that urge from the periosteum and the synovium to activate bone laying down and osteophyte formation, then that could be very helpful. And two, when we improve the circulation in the area, if we do have any medications, supplements, herbs on board, then we are improving the delivery of those products to the joint if we have better blood flow in and out. And so then what else can we do? We can do massage. And think about just the pain generation with osteoarthritis also. And just even the negative cytokines, the pro-inflammatory cytokines that are released, a lot of that is perpetuated by the dysfunctional neurologic system. So it's not that we just want to look at the end product and say, oh, let's fix that. We want to get at the cause and help downregulate and wind down just all that excitation and facilitation in the spinal cord and the peripheral sensitization. So how are we doing that? Well, we can do the overall massage. We're going to, of course, do acupuncture and photomedicine, and we can just release all that tension that has developed not only around the joint, but all over. If you're lame all the time and your head is bobbing up and down, you've got problems all the way down your back. And so this is really a whole body treatment. Why are we cutting and just giving anti-inflammatories when there's so much of the body? Look at how much baby enjoys this. Yes. And he's not even living, but you can see how pulling on the fabric, which in the live dog would be myofascial fabric. Here I am pulling on the side, and just like with myofascial fabric, it is affecting head movement. And so we're cognizant of that. I'm probably doing it a little more roughly than I would a real dog of this size, but I'm just trying to show you what's going on. But the more we can move, have the tissues move and become normalized, the better function is going to be, the more activities of daily living they're going to be, the more range of motion they're going to have. And that fascia that is keeping that range of motion just tight is going to relax, and so they can get around better. All their organs will improve from that because they'll have that blood flow, they'll have that movement, that just redistribution of fluid. It's so important. And so with all the modalities that we include with integrative rehabilitation and physical medicine, we bring that to bear. And why would we want to do surgery at that point? I mean, yeah, if there's a fragment that's bothering the joint, okay. But look at how much else we can give to these patients. And yeah, you might be saying, oh, I already do acupuncture and I do some E-stim across the joint and they're still lame. Well, did you actually palpate everything? Usually you're going to miss out on these flexors. You haven't done a full palpation. You haven't identified the long myofascial strains. Yeah, oh, I felt trigger points here and here, here and here. But did you feel how there was a long line of dysfunction from the digits up the extensors and to the triceps, to the infraspinatus, to the teres major, and all the way up to the back, to the midline? Did you treat all of that? Did you release it? Did you release the rhomboids here in this interscapular area? How much time did you spend? How much time can you spend? Are you working in a corporate job that only gives you 10 minutes to treat a patient? Well, now there's a problem too. So this is an opportunity to get your life straight and think about what's important to you. Do you want to do a great job treating elbow pain, or do you want to be stuck with 10 minutes at a time and there's not much you can do for patients? Your choice. So, bonus learning. With which tissue is the joint capsule continuous at its proximal and distal extent? This surprised me, and it opened up a whole area of study that, of course, I'm putting into the MOVE course. So if you're one of our current students, you'll get to enjoy that little section too. Give you some time to think. With which tissue is the joint capsule, think about of the elbow or the knee, continuous at its proximal and distal extent? Did you ever think that there was anything but the joint capsule wrapping around the joint? No, you probably didn't. Well, periosteum. So I encourage you to take a look at this article, download it. Free shopping online for open access articles. This is available to you. Clinical relevance. Periosteal and synovial skeletal progenitors cooperate to form osteophytes and osteoarthritis. I just alluded to that. But that's because the periosteum and synovium are continuous. And there are different layers to those. And some of them are more active, some of them are more fibrous and structural. Read up on that. Thought question. Can proactive treatment with integrative rehabilitation and physical medicine inhibit osteophyte formation through modulation of molecular factors and signaling pathways? Yes. Let's get to them earlier rather than later. Question 2. Which fascial structures protect the elbow from overextension, stabilize it, and aid in the distribution of forces even without the assistance of muscle activation? This gets into our whole realm of fascia that probably for many of you, if you have taken a rehab course before, at least I've looked at some of the books and fascia isn't in there. So fascia being extremely important, extremely ubiquitous, and vital for stabilization of our structure and also for allowing movement. And so if you did a dissection and started to just cut away each little layer and then we're testing, let's say it was a cadaver, naturally occurring disease, and they died. And then you see, okay, which fascial structure is keeping that elbow from extending more fully, just even looking at extension. And so even without muscles, even without being alive, what is contributing to that mechanical stabilization? So answer, look at this article. You can download this as well. The collagenous framework and attachments of the skin, the deep fascia, and the extensor carpi radialis muscle. The biceps brachii muscle was also significant in greyhound. So these other ones that I mentioned before, the collagenous framework, the skin, deep fascia, and extensor carpi radialis, those are for a broader range of breeds that they studied, but just the greyhound had a significance with the biceps brachii muscle. And so when we're looking at improving or working with range of motion restrictions, just general, never force. I mean, I really am very wary about passive range of motion because, oh yeah, dog screamed when I extended the elbow. Dog lame. Dog needs surgery. So none of that. None of the screaming, wanting to get the dog to scream. Oh yeah, they have neck pain. They screamed when I put them like that. No, that's old style. We don't do that anymore, at least not in my program. And so if we're talking about extensor carpi radialis, for all you MAV grads out there, what acupuncture channel follows the extensor carpi radialis? And biceps brachii muscle. Think of the acupuncture channels there. You don't even have to think about acupuncture channels. You can think of the muscles themselves and the fascial lines, the functional or kinetic chains, but the functional anatomy that connects it all. So that's what we want to palpate, and that's what we want to treat. Question 3, which integrative rehabilitation and physical medicine modalities impact fascial health and thus may serve in a protective role? Acupuncture, photobiomodulation, medical massage, and even just movement, stretching. And think about agonists, antagonists, so reciprocal inhibition, your muscle spindles, all kinds of stuff to do, water therapy, and it goes on. So join us again next month or email me, narda@curacore.org, or sign up for a course, MOVE or MAV. Take care. Thanks for joining us.